Hello, I'm Nora Hanna, Chief Engagement Officer at Sun Health, and I'd like to welcome you to this episode of Coffee Connections. We created this series to help you stay connected to the latest developments in healthcare and wellness by hearing directly from experts in our own community. The Sun Health Foundation is committed to ensuring that this region has access to the most recent medical and technological advancements, and that we attract the best and the brightest practitioners for our care. The foundation supports scholarships for healthcare workers, programs at our Center for Health and Wellbeing, and we are the exclusive philanthropic partner to Banner Boswell and Banner Del E. Webb Medical Centers. Our mission is to empower others to live longer, healthier, and more purposeful lives. So we're excited to be able to offer you this unique access to these expert resources. Thank you for joining us, and I hope you enjoy the presentation.
Thank you so much. I want to say good morning, and I just thank you. I just love the venue. I love the coffee conversations, and I thank you to Sun Health for the invitation to come and speak and kind of share what I do and how we do it. I could also just like to take a moment to thank Sun Health for all that you do for the community. I was aware of some of the hospital work, but I wasn't aware of the community work that was being done. But talking to Nora and her team, it's really excellent what you're doing. Revolutionizing Healthcare from the Inside Out, great title. When we sat down to talk before about what the tone of the presentation should be, the question always comes up, what is an interventional radiologist? And so for me, it's a very personal question because I had been in training, med school, residency, fellowship, and then got out and started practicing. And I was back in New York. I'm from the East Coast. And my father had atrial fibrillation. And so we were in New York together. He was at NYU seeing his cardiologist. He said, hey, can you come to the appointment with me and just kind of listen and kind of hear what's going on and hear what the options are. And so within the consultation afterwards, during the consultation, the cardiologist said, hey, you're doing fine anticoagulation, but there's some options. And this is 24 years ago. Would you think about having an ablation to find the source of where the arrhythmia is starting in the heart, and then try to do an ablation to stop that from happening? But he was doing well on anticoagulation, and we decided to kind of defer that for a bit. Afterwards, we went out to get some breakfast. So we're sitting at breakfast, and he said to me, could you go and do that in the heart? Do you have the skills to do that? And I said basically what oftentimes we say as interventional radiologists, we say, not the heart, not above the clavicles, so not in the brain, but everywhere else. So this is off of our Society of Interventional Radiology website. And they do a pretty good job, I think, of describing what we do. It's really hard to kind of capture it all. But interventional radiologists are board-certified physicians who use image guidance. We mentioned X-ray, CAT scan, ultrasound, to help deliver. This kind of a key word that we use a lot is minimally invasive. And that's basically comparing what we do to, say, a surgical procedure with a laparoscopic. And then we talk about targeted treatments, being very selective in what we're doing. And the idea is for a quicker recovery, to basically get somebody out of the hospital faster, and back on their feet, essentially. So IR addresses many of today's toughest medical problems, including vascular conditions, blood vessels, both artery and vein, many types of cancer, men and women's health conditions with minimal discomfort and unprecedented precision. And the folks that do this, we call them interventional radiologists, which is how I would describe myself. And so I think really when it comes down to really practicing IR well, it's in a team. It's a team. And I'll show you how that team works. And it's collaborative. And so we're collaborating with other physicians, particularly when you're in a hospital-based setting. And yes, so we'll see patients in the hospital, follow-up after treatment and in the hospital. This is a little hard to see back there, but this is basically how do you get to be an IR? What does it take? What's the training pathway? So medical school, and then it's kind of evolved a bit, how you get to where you can actually practice. So there's probably a 6 to 7 year differential in what it takes. So a year of internship, and it can be in various specialties. It can be medicine, it could be surgery, it could be a transitional year where you go to OBGYN as well as surgery and elsewhere. And then there's a block here of actual radiology training, so interpreting images. And nowadays it's evolving where some IRs feel that it's more of a clinical type of specialty and imaging is less important. So that's one of the things that our specialty is kind of evolving in now, is how much training do we need in diagnostic radiology. I personally believe a solid foundation is really key, because oftentimes a phone call will come from the referring physician saying, hey, I've got this patient with this problem. And sometimes actually the next step is more information. So what tests do we order to be able to answer that question and to plan treatment better? So we mentioned minimally invasive. So we're always comparing ourselves to surgery, whether it's open surgery or laparoscopic surgery. As much as, so smaller incisions, faster recovery. So as much as we think we're doing a great job minimally invasive, other specialties are also evolving. So for us, like doing, say, a lung biopsy for a nodule, now we have interventional pulmonologists who can use robotic technology, which I think Sun Health also supports that, which is fantastic, to basically get a roadmap from a CAT scan of where that bronchus is that supplies that tumor. And they can go very far out to do those biopsies. They can also look at the mediastinal lymph nodes in the chest to see if those are involved with cancer or not. And so it's kind of that constant evolution. We also have interventional GI doctors who do endoscopy. I'm going to try to remember to show you on another X-ray CAT scan that's coming up what they can do. It's pretty remarkable technology, but it's really collaborative and it's really kind of a teamwork that we operate with. So in the process of putting this together, I was wondering, like, how much can I really show you of what we do in an hour? I found this on the University of Washington website. I think this is an excellent demonstration of all of the procedures that we can do. So up here on the left-hand corner, and again, it's probably hard to see, it says venous access. So venous access goes from something as simple as being in the hospital, needing medication, delivery for either saline or it's medications, and you need what we call a central line. You put something in the jugular vein. Relatively simple procedure for us. It goes on to putting a port in, say for chemotherapy, so burying it under the skin and closing the incision. Essentially, I would say that we are probably the experts at venous access. So with long-standing indwelling catheters, we get narrowing in the veins and we lose those veins for access, and so it's a process that ultimately, in some cases, we have to actually go through the flank and into the main vein, the vena cava, as a kind of a last resort. But we are really the folks of last resort for venous access, or the specialists for venous access. Then we also have what we call drains and tubes. So putting a tube in virtually any organ. It could be in the chest to drain fluid from around the lung. It could be in the gallbladder. You just saw a little napkin diagram. If the gallbladder is inflamed, the patient's too sick to go to surgery, we can put a tube in there to temporize that patient, and later on they can go to surgery. If someone needs feeding, whether short-term or long-term feeding, we can put a tube in the stomach, gastrostomy. If for some reason, if we feed them in the stomach, they may have reflux, which is a risk for aspiration and for pneumonia, we can put a tube in that goes through the stomach and then goes around into the small intestine and preferentially deliver food or feeding through that jejunal, small bowel feeding. We also have nephrostomy tube placement, which is basically a tube that we go into the kidney directly to relieve that obstruction if there's infection. And then we can also have a tube that goes into the kidney and then goes down into the bladder, nephroureteral. We can put a tube directly into the bladder if we need to. If there's an obstruction and the patient can't void. We showed an example, the first case we talked about was the piliary drain placement, just putting something into the bile ducts to drain it out. And then we also manage those tubes as if they get clogged or they fall out or what have you, we manage that as well. A big thing that we do is embolization. Embolization is basically blocking off vessels using a variety of materials. We can use a foam, we can use particles, beads, we can use radioactive beads, we can use ethanol, alcohol to destroy the vessels, depending on what we're trying to achieve. And so we look at it in terms of, for trauma, if there's a pelvic fracture, patient's bleeding, we can do an embolization to block that off. Very common one that we see is gastrointestinal bleeding, which is a very difficult one to be with because it basically, it can start and stop. And so our goal is to find out where the bleeding is coming from and generally put a small coil in to block that vessel and to stop the bleeding. I'll show an example of, here it says retroperitoneal hemorrhage, a patient that presents with hemorrhage in the belly, and we'll see how we manage that. I'll show you some pictures of that. So kidney hemorrhage, a big one here at Del Webb is postpartum hemorrhage. So after delivery, the uterus is not contracting or there's an injury and it's bleeding, we can access the artery and block off the uterine artery to stabilize that patient.
Hold the mic closer to your mouth.
Thank you. Yes.
Thank you.
Thank you. So a big new development is prostate artery embolization. For basically outlet obstruction where you difficulty voiding, so you can avoid surgery. We try to shrink the prostate down over time. We have pulmonary, abnormal connection in the lung. We can go in and we can embolize that as well. A big field now that I actually do a lot myself is interventional oncology, which is treating cancer with a variety of techniques. We'll do embolization. We can do what's called ablation, where we actually destroy the tumor in the body rather than resecting it. And there's various reasons why we would do that. A lot of it's the patients, if they're stable, other medical conditions, comorbidities. Portal interventions, if patients have cirrhosis, so liver scarred, and vessels are dilated and that can cause bleeding. The big one is esophageal varices, where there's large vessels in the esophagus that can bleed. The GI doctors can also put a scope in and try to ban those, but in those situations where they can't stop the bleeding, we can go in and embolize those vessels as well. Then we have dialysis interventions, where they create like a fistula or an AV graft to do dialysis. We have venous interventions, putting in a filter. We can take blood clots out of the veins in the leg and stent if necessary to keep flow going. And then we have spine interventions where we have sacroplasty or, well, actually more commonly, vertebral augmentation for a compression fracture. We can put cement in there to stabilize those fractures and give pain relief. So it's quite a long list. Sure.
You guys are the experts. If we find ourselves in the hospital with the need of any of these things, what if they don't have a IR in the hospital? How do we get your service?
That's a great question. So, no, it's a great question. It's a very good question. So I'm gonna go through after the slide, I think, and talk about the team aspect. And so me and my colleagues, we cover every day of the year, 24/7. So we're always available. Is the answer to that? But it's a great question. Yeah, and we're basically hospital based in our practice, so we're always available.
So all the hospitals around here have an IR?
They do.
Okay.
Yes. Boswell, Del Webb, always. Thunderbird and Estrella, always. So yeah, we're part of that team of all the other docs in the hospital who take care of folks. Yeah. So we mentioned embolization. We mentioned ablation, which is destroying tumor cells in the body. So this is a gentleman who's one of the founding fathers of radiology, Constantine Cope, and developed a lot of techniques early on in the 60s. Had a chance to meet him, interviewed at University of Pennsylvania in '99, and he came over and sought me out, and he said, hey, I saw on your CV that you're in Brooklyn, you're at Kings County Hospital. He was an intern there. Walter Reed was an intern at Kings County back in 1871. And so he said, hey, join me for lunch. And so we sat at a table and just talked about interventional radiology and about Kings County and kind of caught up. But truly, as Nora mentioned, like standing on the shoulders of giants, that's what we do every day. What we do technique-wise is built upon folks like Dr. Cope. So these are little quotes from, he actually passed away in 2016, so just some quotes from an article written by him. So he talks about, his daughter talks about the catheters that they used back in those days. They weren't pre-made. They came straight and you had to heat them the right way to get the right shape, that whatever you like to use for that. I'll show you an example of this Cope loop that he developed. It's just such a simple idea. It's actually just genius. And that's kind of what the company that he worked with to develop that said so often. It's just that the simplicity of it. So he basically developed this idea that you would put, here's the catheter when it comes, and we still use this today. It's straight, it has these little side holes that have been cut here to do drainage. And he said, well, what if well, before this they had surgical drains that they'd sew into the skin, they'd slide out, mouth position. So he said, what if we just make like a little, we call it a pigtail, like a little curlicue at the end. And his idea for that was to put this suture, little string that went through, and then when you tugged on it, it would cause the catheter to bend and lock in there. This really, I mean, you can remove it, it takes some doing, but it really makes these catheters stay in much more easily, much more reliably. And so over the years, the innovation has really been what material the catheter is made of, how flexible it is, how easy does it slide forward, and also just innovations in the locking mechanism. How do you lock that in place? So here's a, sorry for this, I apologize, they're not the best image, but here's the loop. These are little side holes where the drainage occurs. Here's a marking band so you can know under x-ray where this is sitting. Is it in the right place or not? Has it come back? And then this is the suture. It comes out and it locks here. When you pull on it, the slack goes out and it pulls this forward to here and it locks it in place. It's just simple and genius. But he did a whole bunch of other things with access needles as well. And we'll talk a little about that too. So I would say, I think the principle or a principal technique is that we use imaging guidance. And I should have added that he's actually an internist. He wasn't trained as a radiologist. He was an internist that came in just because of the innovation. Yeah. So I guess there's some, do you have to be a radiologist with imaging background? Maybe not, but you also have to be a genius, I guess, also to do that. So we use imaging guidance, X-ray, CT. We actually mentioned fluoroscopy. Fluoroscopy is basically continuous X-ray. It's 30 frames a second, it's taking the picture, and you can look at things real time. You can move wires and you can see what you're doing in real time. CT is a snapshot, basically. It's just an image snapshot. CT fluoroscopy allows you to, let's say for a lung biopsy, you can tell the patient, in the machine, you can say, hey, hold your breath, and you can step on the pedal and it will take an image, and you can move the needle real time, and you can see it going into the nodule. So very effective. Ultrasound, MRI less commonly, but some folks do use it. It's a small needle access. Generally it's a hollow needle with a little stylet that goes through it. Needle goes in, you take the stylet out. Now you have access from the outside into whatever structure you're trying to access. It could be bladder, it could be an artery or a vein. And then you put a small wire in. And this is also the innovation Dr. Cope was this Cope wire that he developed that we still use today. Highly reliable, it's excellent design. And then you dilate. You take progressively larger little tubes over that wire to make a larger tract. And then you go ahead and put your tube or your catheter in. So this is a room which is at Boswell. We call it the hybrid room. It's down in the OR. A little hard to see here. Control room. Back in here is the actual machine that we use to do our mapping and planning for our procedures. And so
I apologize, doctor, for my phone going off.
Oh, no, that's totally fine.
Sorry.
No, you're fine. Thank you so much for that. That's okay. So here is the machine. So basically, the source is going to be here. So the X-ray will come from here under the table, and it's captured in this image intensifier. And then it's translated into an image that we can see. And there'll be a monitor, you can't see it here, but we can watch things real time. What this machine can do though, because we call it a hybrid, is that it can spin, it can turn, and as we're injecting, we can gather images that will be reconstructed to be like a CT scan. So it helps us, and I'll show you some examples of how we can map out what's supplying a tumor to plan treatment. So this has really elevated our practice and be able to really do targeted and selective therapy. And then, as large as this is right here, nowadays, it's been reduced to here. We can get it in that small footprint. So this is from our SIR website. I like this image a lot because it shows a lot of what goes on. This is like a typical IR room, procedure room for X-ray. So, patient laying on his back. We've got a gentleman here with gray hair, so I'm assuming he's teaching, a lot of experience. A young trainee, and then we have a nurse at the head of the bed who's monitoring the patient. And we do virtually all of our procedures with what we call moderate sedation, so like a twilight, essentially. And continuous monitoring. So this patient here, so the first thing I looked at when I saw this was I went right to the screen and I said, what are they doing? What's the procedure here? So that first napkin drawing we talked about with the gallbladder, liver, and the bile ducts is, I'll make this a little bit larger here, let's see. Let me just do this first though. So we have a needle that's going in to the patient, upper quadrant. We can see that needle right here, right? And then what they've done is they injected this contrast, this quote unquote dye that we call, that we can see under x-ray. And it's filling the bile ducts. Now the thing is, this should flow down into the intestine because we have what's called a stent in here. And that's placed by the GI physicians. So they placed the stent there to drain that bile down. So I'm trying to figure out in my own mind, like, why do they do that? So little clues though, I think here. There's some clips here. So the gallbladder's probably been taken out. It may have been a very inflamed gallbladder, difficult procedure. There may have been some injury to the bile duct, the common bile duct here, and a leak. Because I see a catheter here with these side holes. Not quite the Cope loop has been formed, but it's there and it's draining. And so they're trying to access here to see if they can relieve that obstruction or drain that out temporarily and then figure out, do we take that stent out and then put something more internalized? There may be a catheter that goes out and then goes into the intestine. So this is just didn't reproduce very well here, apologize for that, but just to give you some reference points. So that stent here is sitting in here, okay? So we mentioned the teamwork that goes into this. So two of my colleagues, I think between the three of us, we have enough gray hair and probably 75 years of experience between the three of us. So we're looking to expand and hire a fourth radiologist, interventional radiologist. And so we all feel collectively like we want somebody young, somebody that can teach us also what the new stuff is coming out. And so Dr. Kelman's Dr. Hugh, and so that's my colleagues who I call for advice and ask them for support. And then our practice probably 4 to 5 years ago evolved that we started using physician assistants. And it's been really great for us. Sean on the left here has been with us for probably 4 to 5 years, and just phenomenal. It just helps us with communication with other services. He does some procedures for us as well, helps us with patient management as well. And then Tori joined us about 6 months ago, and equally I think has potential to be a star. This is our team at Boswell, nurses and techs. You know these people. Yeah, they're, well, you can give us a review, but we get lots of reviews though. We know they're phenomenal, I would say. They're just caring, great people. Incidentally, they're standing outside of this area right over here would be our recovery area. They're standing where the new endoscopy suite's going to be at Boswell, right behind there, the old ER. So, yeah, just absolutely phenomenal folks. Our Del Webb team here, equally is great, yeah. And so you mentioned collaboration. So we really talk to virtually every physician in the hospital. Maybe not rheumatology, maybe not for joints and stuff, but everyone else. Pulmonologists, oncologists, gastroenterologists, the surgeons, you name it. So I'm going to just show 3 examples of basically patient care and kind of how we interact with other specialists, what our techniques are and what we do. One of them is going to be a patient for an embolization for bleeding in the abdomen. The other one will be what we call a cold leg, so to speak. Somebody has an acute onset of coldness in their lower extremity. Usually it's arterial from a variety of causes. It could be a blood clot that goes down and travels down there. And then how we get that out. And then the last one will be a patient with cirrhosis and liver cancer who's done quite well with Y90 therapy. And that, again, involves that hybrid room at Boswell and the mapping and the planning. We'll kind of go through how we do that. So our first patient here, kind of a complicated history, abdominal pain in the past, multiple visits to the emergency department, but sitting at home with a sudden onset of chest pain as well. So that something is different. The patient comes in, examined by the ED physician, and really give this physician kudos because they actually ordered a CT angiogram, which is a very particular type of study, looking at the blood vessels, arterial blood vessels. And it's a matter of timing and technique. So we do a CT scan, it's called a spiral scan. We put them in the machine, the x-ray is going, and the patient's moving. So it's kind of a spiral acquisition that we get. And then we get a 3D set of data. And we can slice that any way we want. We can do what's called axial this way, we can do a coronal this way, or we can do a sagittal, look at you from the side. And so this really helps with diagnosis for us and for planning. And so I think the operating diagnosis here was that the patient had some sort of dissection, some sort of separation of layers of the aorta causing this chest pain. In fact, I'm showing you only one image, which probably only the radiologist here in the room will be oriented to, but I'll try and get you oriented. So the patient's laying on their back. And we've taken one slice through the body, kind of like this. And our convention is to look from the soles of the feet towards the head. And so, to get you oriented, so this is back of the patient laying on the table, spine, vertebra, front of the patient, right side of the patient on this side, left side here. So, with the CT angiogram technique, we're looking to fill the arteries with the contrast. Wait about 25 seconds just for the heart to pump, to inject here, goes to the heart, it gets pumped out, in about 25 seconds, those arteries are lit up. So what we see here is we see the aorta, that large vessel that comes out, goes down, brings blood to the intestines and to the lower extremities. But there's something equally bright, or almost equally bright, right there, which is abnormal. And then we have all this, which is not normal. Here's the colon, so intestines, right kidney, and then you got something here. So this is actually hemorrhage, it's blood. So the patient's bled, and then fortunately, it's bled to the point where there's a bit of pressure here, and so it's kind of contained that bleed a little bit for now. But you really can't walk around with this. This is a risk to rebleed that could be catastrophic. So we do, well actually this illustrates the coronal imaging, how we can section the 3D data that we have. And we can see this is showing the chest and all the way down to the pelvis. And just some of the structures here, you know, obviously heart, here's the aorta coming out, and again, we're sectioning one area, but if we look here, we see this pseudoaneurysm. And then we can kind of blow this up a little bit, get a little bit better view, pseudoaneurysm, and then we're going to see from the angiogram that we do that there's actually another one here. So, you know, before we figure out like why this happened, we kind of address the issue at hand here. So, speaking of these catheters, this was called a Sauce Omni catheter, Dr. Sauce, who that was his preferred shape of that catheter. Now they're mass produced. So that's a nice one to kind of hook into this vessel called the superior mesenteric artery. That supplies really all the small intestine, the colon all the way up to about the left upper quadrant. If you look here, we see a branch coming here. There's some narrowing. I think this actually is probably just from the wire kind of causing what's called spasm, exactly. And then you get a hint that there's something like a blush here. And then if we go a little bit further out and inject a little bit more, I've changed the catheter here. This is a microcatheter. It's about 2.8 French. So 3 French is 1 millimeter. So it's less than a millimeter, small. And we can see that there's a pseudoaneurysm right there. All right. Now, these vessels here are going to the pancreas. So there's quite a few of those. And then if we inject a little bit more, go a little bit further out, we see this pseudoaneurysm and we see another one here. And the problem here is that if you decide that you're going to embolize or try to block vessels off from here, things that you administer, they may go out this way and then you're not quite sure where they're going to go. So you have to embolize it in a way that you don't sort of block here and then the flow comes back the other way. The body's quite resilient, which is good and difficult at times. So we have to get further out there. And this is with this technology, with these catheters, I mean, it's absolutely amazing how far you can go out into the vasculature with these. So we get out there, but this is good, but not good enough. If we block it here, these vessels will come back and this could bleed, right? So we have to get a little bit further out. So we get a little bit, just enough to get beyond there, right? And then we have to choose what we're going to embolize with. Are we going to put a foam solution there, particles, or are we going to do coils? So the coils are very controllable. We can deploy them, and with the new technology, we can actually put them all the way out and then decide if we're going to release them if we like where they are. If we don't like where they are, we can actually pull them back in the catheter and reposition, which is a huge advance for safety. So here are the coils. This one here is going just beyond here and into this branch here, and we've coiled it all the way back. This coil right here is actually sitting in the pseudoaneurysm there. And then these are blocking the vessel more proximally here, more towards the beginning of the vessel. We do a post-embolization angiogram to be sure that we've got things where we need to be. Now, I probably should have mentioned that these images are a little bit confusing because they're subtracted. So what happens is we take one image and then everything after that, we overlay it, and we want to take out all the other structures. Now, problem is that you have the bowel, which is constantly moving, so you really can't subtract that out very much. So that's a little bit of this artifact or motion here. And then this patient was quite frankly, was struggling, wasn't doing great. So they can't hold their breath and they can't follow directions. And so this is the kidney here with contrast being excreted in the urine, and it's just moving. So that's why it looks a little bit busy, this picture. But the key thing here is that we're not seeing any blood flow to those aneurysms there. And so it's always nice when you get some follow-up on these patients. So this was before the embolization. This was taken in the hospital 2 days later. They were having some unusual pain again. Want to make sure there was not a rebleeding or anything. And already in 2 days, we've seen the hematoma start to get smaller. It's resorbing. And again, the patient has some chronic GI problem which is trying to be figured out. Patient comes back 6 weeks later. So the coils are all here, the artifact, and now the hematoma is gone. The body's resorbed it completely. Do I have one? Let me just be sure I didn't miss.
Oh, was there something that came up later?
I thought I had a picture of, I didn't capture it. They actually went in, the GI doctors, and actually they felt there was an issue with the distal part of the stomach, but things were not emptying properly, and they were going to put a stent in there. Maybe it'll come up later, but that was a good one to show as well. But so our second patient is a patient that had a little unusual history of a 2-day history of just some pain in the left leg. Leg felt cool, wasn't getting better. Patient came into the hospital, evaluated an ultrasound first, thought we saw a blockage or occlusion in the vessel, and got a call from the vascular surgeon who said, hey, I'm not really comfortable with this patient waiting till the next day. I really would like to have him treated today. I can't get into the OR. It's a lot of emergency cases, and I feel better if we did it today. Would you mind taking care of the patient? So I said, no problem. So this comes back to a question patients have, who's doing my procedure? So there's 3 specialists who kind of do arterial interventions. And so that's where it's a little bit like, well, who's my physician, who's doing it? We sort of share a lot of these skill sets, which is good for patient care. You want somebody available that can take care of you. So we had availability, and we said, sure, we'll go ahead and do it. So we had a little bit of a sense on the lower part of the leg what was going on from the ultrasound, but we really can't see well into the pelvis. So what's here, the patient's laying on their back, and we're actually coming in from the right groin over here. So we're looking down on the patient. And we've got that Sassamni catheter again with that little curve. We've injected the contrast, and we come down here. This is the internal, which goes into the pelvis, into the bladder and other structures. And if you follow down here, narrowed. So the thought was that there was some narrowing here. When blood slows down, it can clot a lot, or it can form little clots, and then it can embolize. It can go down the leg. So I called the surgeon up with the pictures, and I said, hey, you know, what's nice is that you can almost like FaceTime. You can basically show them live what you're doing, and they could be anywhere, which is great for healthcare. And then we talk about what the plan is to take care of this problem. Now the thing is, we want to get flow down the leg so we can figure out what's happening further down. So this is actually, we call it a sheath that goes over, and it allows us to basically work through this. And we can inject through it and see what we're doing, kind of real time. This is a delivery device, but the stent is here. And the stent has a Gore-Tex covering to it. So it's called a covered stent. So if there is any clot or anything in here, it'll be caught by the fabric, and it'll be excluded. So it won't go back into the leg and cause a problem distally. So then we do is we basically deploy it, we basically unsheath it, we put a balloon in to kind of tack it up, and then we check our result. Looks really nice. Yeah, I'm really happy with this one here. This looks really good here. And then we go, okay, where's the next problem? So then we keep working our way down the leg. And this is the patient, again, laying on the back. This is the femur here. Kind of hard to see it, but we subtract out a lot of that. But there's a little bit of motion there, enough that you can see the cortex and you can see the bone marrow in here. And then you've got the catheter sitting here with a little gentle curve on it. We inject the contrast and we see, oh, there's a problem. This is basically distal thigh area is where the issue is. And then there's little clues as to how long has this been a problem for. And quite frankly, when I saw this, I was thinking, I see all these small vessels and maybe this is a chronic problem. Maybe we can't really get a good result from this immediately. But the risk here is that we're going to lose the foot. So take a catheter, which I didn't show a picture of because it's a pretty nondescript catheter, but in the catheter, it can sense when it's touching clot and it can draw the clot out. It's pretty remarkable. So we basically park that catheter here and we kind of push it in and we pull off some clot, whatever's there, and we just keep going. And we go from here to here. So again, not perfect, right? We've got all this atherosclerotic or this calcified plaque here, but we've got flow now going down, which is a huge improvement. And this is kind of what we pull out. That's some of the clot that's there.
Did you find out whether the history of a cigarette smoker or not?
Yes, yes, yes. And then we kind of like keep looking further down the leg. We need to get flow all the way down to the toes, right? So we go down there and we say, okay, well, this is kind of where we treat it here. It's kind of open now. Not too bad here. We've got flow. And then there should be 3 vessels down here that we see. We don't really see 3 vessels. So we go back down again with the catheter and we remove some more clot. And we at least get 1 vessel here. And then this other vessel, this is basically a continuation of this vessel here. And then the other vessel is good, but it's not direct flow. It's got occlusion, and then it kind of, all these other small vessels kind of fill in that vessel. So basically at this point here, we basically put a clot-busting drug called TPA in there, and then I can hand that patient off to the surgeon. He can decide is it going to be bypass or atherectomy or how we're going to manage that patient. So kind of a collaborative effort. Last patient here is a patient that I saw back in 22, as a matter of fact. And again, getting follow-up, but also not always perfection, but making an impact in somebody's life. So this one here really kind of stands out for me, kind of keeps me going. So this patient is in their 50s, presented to another hospital with what we call hematemesis, so basically vomiting blood. Underlying problem here is that the patient has cirrhosis in the liver. So the liver has now become like a resistor. So all this flow that's going to the liver from the intestines is basically blocked to an extent. Has to find somewhere else to go. Common place to go is in the esophagus, the veins in there. And so those veins have dilated and they've ruptured and now it's life-threatening. So they put a scope in, they band the varices, the veins, they band them, and then they stabilize. And we get a CAT scan. Well, did I show? Okay, so I did it more this way, I apologize. So CT scan on admission shows that the patient has a right lobe of liver tumor. The liver looks nodular, cirrhotic. I'll show you what that looks like. And basically has an underlying hepatitis infection. Undergoes a biopsy of this mass in the hospital. It comes back what's called HCC, hepatocellular carcinoma. So it's arising from the liver itself. Patient comes to me for a consultation about a month later. And we meet with the patient. We want to basically assess what's the patient's current functional status. Can they really handle treatment, and what level of treatment can they handle? We look at all the liver function tests, other tests for coagulation, for bleeding, et cetera. One of the big ones to look at, these tumors can secrete a chemical called AFP, alpha-fetoprotein. It's a nice way to monitor response to treatment. This is about 5,000, which is very high. And then we go over the imaging studies, and then we try and, with the patient's input, figure out what is our goal here. So, imaging review. So, this is an MRI image. So we showed some CAT scan images before, but same idea. Patient's laying on their back. This is the spine here, and we're looking up towards the head. It's that slice again. So heart. There's aorta, which we know well. This is over the left side, so this is going to be the spleen. Here's liver. This is basically the top of the liver. The diaphragm is right here. Lung is here. And this is all tumor there. And I apologize, not projecting great, but the borders here, the borders of the tumor are essentially here. Right, so large tumor. And then the other thing here that makes you pause for a moment is that the tumor is now extended into this vein, this portal vein, which is not a good prognostic sign at all. And just how far down this tumor extends. These images are going down through the liver. So this is a little schematic just to kind of clean up these images here. But essentially, this whole right lobe of the liver is just tumor, essentially. And then what it's done is it's grown into this branch of this vein that's coming back. The liver basically is a processor, right? So you eat, digest, you absorb. It's going to bring all that back from the intestine, all that blood, with nutrients and everything to be processed. So here, this tumor has come into this right portal vein branch and now has grown over to the left, which these tumors can commonly do when they get large. So that's kind of just the sense, but this is quite large. So we meet with a patient and we look at the imaging, and quite frankly, I'm a little bit disappointed at how extensive it is. And then the question is, can we offer something? And, because the hardest thing is to have someone come into your office and you say, well, I can't do anything, and they've got to leave. And then there is the option of medical therapy here, like immunotherapy, but it takes time to work. And so this is probably 2-3 months longevity at this point after we've seen this patient. And so time is of the essence. And so I call a colleague of mine, does a lot of these, and we kind of look at the images together and we kind of say, well, before we say no, let's do what's called a mapping angiogram. And this is where that machine that we have at Boswell, the hybrid machine, really comes into play. So we're thinking about doing what's called Y90 or yttrium-90, which is basically radioactive seeds, essentially spheres. There's 2 devices. One of them is like a resin where the radioactivity is like stuck to the resin bead or the sphere. And then there's one which is encased in glass. It's a little bit like Coke and Pepsi. They get the same idea. It's radiation, it's sugar, right? But yeah, so just to give you some idea how small these spheres are, they look at it in microns. So a red blood cell is about 7 to 9 microns. These are 10 to 20, 20 to 60, so these are small. These are very small. So we call it radioembolization because it's radioactive embolization, but there's really more of an effect of these being implanted than blocking off vessels, so to speak. And what it does is it emits this beta, which is like basically a high intensity electron that comes out. It doesn't travel very far, which is perfect. So you can actually not damage any adjacent liver, or not very much. The half-life is about 2.67 days, so we talk about 4 half-lives as being not a whole lot of activity left. So within 2 weeks, the radiation's worn off. But the radiobiology is the effect can go on for months. And so if we have a patient that's a candidate, once we've treated, we wait about 3 months to kind of reassess and see where they are. So first step is to get this what we call this planning or arterial mapping angiogram. And then what we do is, just for safety, these tumors can have what's called shunting, where they bypass. The flow comes into the tumor and it goes right to the lung. So if we're giving it into a high shunt situation, we're radiating the lung more than the tumor sometimes. Another check. So we go back to the room and we put a catheter in. This is back in December 2022. And we start getting some pictures here. So I apologize, but we're in the hepatic artery here. Here's that little microcatheter that comes out. This is a different shaped catheter. Tried a few of them, wasn't sitting stably, so this happened to be the one that really kind of worked. So you try a few of them. The microcatheter out, we inject. We can see the angiogram here. This is all the tumor that we're seeing there. But at the same time, the machine's spinning, so we can get a CAT scan image. And we kind of all know where we are now, right? So we're laying on our back here, spine, looking up to the head. And then from the MRI, we saw that the top of the liver, that's all tumor. That's all tumor in there. And we mentioned that tumor going into the portal vein. And this is really, I mean, most impressive I've seen is that we can see these large vessels coming in, and this is the tumor. So it actually grows with the blood supply with it in there. This is the MRI image. Again, this is all tumor up in here. And we just keep mapping. Again, there's tumor in the portal vein here. And then we've got our information. We talk to my colleague and we go over the images and we decide, you know what? We'll just start small. We'll just try to take a few of the vessels safely and see what happens. So January 2023, I want to show you this because the patient, again, laying on their back. I've been showing you all these images of the patient with the catheter coming from below, from the groin. We can go from the wrist, radial. So the angle was better. I tried all those different catheters and I said, you know what? This is the better angle, and right in no time. So we find our vessel that we want to treat. Okay, we deliver, and then we re-image. This is about 6 months later. And this is the tumor right now. It has shrunken dramatically. And there's no indication that the tumor that's in the portal vein is taking up the contrast. So it's basically dead tumor. But what's interesting is we see this thing, right? Yeah, looks like a pseudoaneurysm from the other one, right? But this is the MRI here.
Not the gallbladder.
No, it's not the gallbladder. So we say, well, I kind of watched that a little bit. The alpha fetoprotein, that measure we looked at was 5,000. It's come down, but it's not quite coming down enough. So we say, okay, let's go back and do another mapping. Let's take a look and see. And lo and behold, it's like a light bulb just lighting up. So it's tumor. There's tumor there. It's recurrent, which, you know, if that's the worst it is, we're happy with that, right? Just that one area. It's very treatable, very accessible. That's the CAT scan image, the spin image from the room. See again, we're in the correct place. We delivered the spheres, just to show the two of them. And then necrosis. It's dead. And so, yeah. And this is where we started, like that large, and now it's down to here. The alpha fetoprotein is 5,000, now it's 4. And so this patient is kind of in uncharted waters now, because like, what do we do now? So now we're going to try to send her to transplant. That's her best shot. Just to describe the liver though, so this kind of nodular contour, bumpy contour is a cirrhosis. So there's two processes going on. There's the cirrhosis going on, which also was going to shorten her longevity. And there's also the tumor. So there's two processes. So really transplant is the best chance for longer term survival, but just highly encouraging, you know, to go. So that just shows the shrinkage of the tumor again. And so just to summarize, like what does an IR do? So we utilize imaging guidance to perform minimally invasive procedures. We work in teams ourselves and we collaborate with other physicians. And the goal ultimately is better outcomes for our patients. So we can do a Q&A if we have time. Thank you. There's Mayo-less transplants and there's university-less transplants. And so I'll be honest with you though, I mean, the large extent of this tumor is going to make them take pause to do that. So, but fingers crossed, you know, yeah, yeah. I think it's preventative care, it's screening. A lot of times with the last patient that we showed with the cirrhosis, I mean, this was a hepatitis infection the patient wasn't even aware of. I mean, it doesn't really cause symptoms until it's kind of like late. And so some of it's just, it's a silent kind of disease, some of these things, but absolutely coordinated care is better. I think, for us, just the nature of what we do, that communication with physicians and sharing information and knowledge and advice, I think is very important. Yeah.
Thank you, Nora. And do know Dr. Haugland is not only an outstanding interventional radiologist, but he's been elected by his peers to be the president of the medical staff too. So not only he's doing a great job, not only for you as patients, but also as a physician leader with the organizations too. And we lean on him heavily for a lot of different things. And to put in perspective for those of you that may know how measurements work, but a lot of times we work in America on different measurements. But when he was talking about how fine-tuned those catheters are, he was mentioning the segments that are even smaller than like 1 millimeter. I always use a pencil as my reference, that the tip of the lead on a pencil is equivalent to what I'd say 1 millimeter, and the eraser is 5 millimeters, and he's working on vessels smaller than that. And he did a wonderful job describing for you all the things that they can do and what they're doing with these catheters and how they're embolizing or how they're doing openings. And think just microscopically those minimally invasive procedures and what they're able to do. Just even sitting in the back, and I know I'm in it every day, and I've been in the industry for about 30 years, and I really enjoyed watching it because it just puts in perspective the wonderful things that we do in caring for patients to make their lives better. And we know that you come to us in vulnerable states when you're sick or you're injured. It was a great question. What are we doing upstream for prevention? And he brought up a great point, because you could do a full body scan, and from $300, $600 to $3,000 to $6,000, get all those slices of your body. He showed you pictures of those. But there becomes the question, and he answered it, that we struggle with too. What if you find those incidentals? What do you do? Same thing's happening with artificial intelligence and the markers we're now able to look at in genetics to say, predictably, 30 years from now, you will likely get cancer. Well, what are you going to do with that information today? So we're in an incredible evolution right now in healthcare, in our industry, with all the advancements. We all want to be looking at wellness and health. We want to go upstream. But there's also decisions we have to start thinking about when you're looking beyond just eating right and exercising. What are we doing when it relates to the technologies that we can now look at for predictive and prescriptive modeling of what we do in the industry for health? A lot's going on, a lot of excitement. I'm in healthcare, and I just really enjoyed what you did today in describing those 3 different patient cases. And from the back of the room, you could just see the nods and the wows, recognizing that we really have a privilege in healthcare to touch the lives of those we serve every day. And we know it. We look at it in our fields, that we know it's an honor, we know it's a privilege, we know that you come to us in vulnerable states. We don't take that lightly. In my role, I also not only look at what we do with strategies, what we do with our experiences, what we do with our physician partners, but there are the capital investments for the future. And that one room, when he said, the hybrid room, let me show you that. That's about $10 million to have that technology. Or the IR suites that we're looking in, and the endo suites that we're renovating and then bringing that equipment behind it. It's about $14 million. When we're looking at the semi-private rooms that we currently have, where a lot of you, we know nobody wants to be in a semi-private room. Don't even need to take a vote. 100% of us want a private room when we go to a hospital. We have those beautiful new towers from the great investments with our Sun Health partners. And the next question is, when are you going to build out those patient rooms so we can all have private rooms and advancements that are tied to that? One floor. So when you drive by and you're like, there's some shelved space up there. One floor, today's dollars, is about $25 to $30 million. That's for one floor. So we will constantly need our partnership with Sun Health related to our advancements in technology, so you can get some of the results we're seeing with our patients that great, outstanding proceduralists and physicians do with us. We're going to need that Sun Health partnership for advancements, not only in that equipment, but for the structure and the facilities. And really, when we think of that partnership, it does go beyond the brick and mortar and the equipment. It goes with the connectivity to our community. And I want to just thank you from a side note here, since I was not the speaker, but looking at all of you taking your time on a beautiful day like this to spend with us, and obviously Dr. Haugland, to educate you and get you involved in some of the advancements in what we do in caring for patients. I want to thank you too for coming today.
Thank you.
So thank you.
Yeah. Thank you. Thanks, Dan. Thank you.
To learn more about Sun Health Foundation initiatives, become a donor, or attend a future Coffee Connections event live, please visit us online at sunhealthfoundation.org or call 623-471-8500. Sun Health, empowering people to live longer, healthier, and more purposeful lives.